Thank you for inviting me. I'm going to speak today about the relationship between cannabis, cannabinoids, and psychosis. Without further ado, just to start off, I am not paid by any cannabis producers, retailers, or people who are opposed to the legalization of cannabis. So just want to make that clear. Just to give you an outline, I'm going to talk a little about cannabis, how it works, how the landscape of cannabis has changed, how cannabis may contribute to the risk of new onset psychosis, and how cannabis might impact those with established psychosis. Most of you know what cannabis is, but I'm always surprised when I give these talks about some misconceptions about certain aspects of cannabis. So I thought I'd try and get that out of the way as quickly as possible. So this is the cannabis plant, and all the action, all the chemical constituents of cannabis are in those hair-like trichomes, those bubbles that are at the end of that hair. That's where all the chemical constituents of cannabis are. And there are many. There are 500 distinct chemical constituents in cannabis. The cannabis plant produces about 150 cannabinoids, and we call them phytocannabinoids, as in plant-based cannabinoids. The ones that are of greatest interest to us are the two that are highlighted here, delta-9 THC, which I'll refer to as THC from here on, and cannabidiol, which I'll refer to as CBD from here on. These are the two main cannabinoids that are of interest to us. Just some very important distinctions between THC and CBD. People often have misconceptions about this. THC is responsible for the intoxicating effects of cannabis. It's what makes a person feel stoned. It's what alters perception. It's what alters cognition. In contrast, CBD does not produce intoxicating effects, does not alter perception, and does not alter cognition. So just keep this in mind as we think about how we might reduce harm in patients who are using cannabis. So you will hear from your patients and from the media distinctions between cannabis indica and sativa. People who I speak to will say they use indica because it gives them a body high, and they use a sativa when they want a head high. There's absolutely not a shred of evidence to support any of this. At the end of the day, what's important to keep in mind is the chemical constituents of the cannabis plant are what produces its effects. And whether it's an indica or a sativa, it contains THC, which is the driving force between all the effects of cannabis. So there are no pure indica and sativa species anymore. These plants have been so genetically modified that it's like saying, what is an American? What are the genes of an American? You know, we come from all different backgrounds, and there's nothing distinct about us. So this is a common misconception that's often pushed by those in the cannabis industry. So how does cannabis work? You know, cannabis has been around forever, and humans have been using it for centuries. But we really didn't know how it worked until 1963, when scientists in Israel discovered delta-9 THC as the principal active constituent of marijuana or cannabis. Despite knowing that THC was the main active constituent of cannabis, we still didn't know exactly how it worked until the very late 1980s. I just want to go over a very simple concept, and that is that of a receptor. Think about a receptor as a lock and a key. Let's say cannabis or THC binds to a receptor, the key going into the lock, and that activates the receptor, producing a cascade of effects. Most drugs bind to receptors in the brain to produce their effects. That's the case with opioids, that's the case with benzodiazepines, that's the case with antipsychotic drugs, and that's also the case with cannabis. But we didn't know that until the 1980s, when we discovered that there are cannabinoid receptors in our body. This is regardless of whether a person smokes cannabis or not. These cannabinoid receptors are present in mice, in rats, in dogs, in birds, and they are there regardless of whether a person uses cannabis or not. We know there are two main types of cannabis receptors, one that's present in the brain, mostly in the brain, and the other that's present mainly in the periphery. I'm not going to talk too much about this, but this is how cannabis produces all its effects on the brain and the rest of the body. We now have the capacity to actually look at cannabinoid receptors in the living brain. These are PET scans from studies that I've done in my lab, showing areas in the brain that have high densities of cannabinoid receptors. And these areas, which are shown in red, that have very high densities of cannabinoid receptors, also overlap with the known effects of cannabis. That is, the areas of the brain that produce the feeling of high, the areas of the brain that involve memory, which are disrupted by cannabis. Once these cannabinoid receptors were discovered in the brain, the next logical question that scientists asked is, what is the body producing that's binding to these receptors? Because as I mentioned, these receptors are present in the brain regardless of whether a person uses cannabis or not, and they're present in birds and animals. So just as there's morphine is an exogenous opioid, or heroin is an exogenous opioid, our body produces endorphins. These are the body's own opioid-like substances. This is regardless of whether a person uses opioids or not. Likewise, the brain and the body produces its own endocannabinoids. The first one is called anandamide, named after the Sanskrit word meaning bliss or anand, and the other is 2-AG. So this is to say that our own bodies are producing natural cannabis-like substances that bind to these receptors. And so the next logical question is, why do we have this endocannabinoid system in the brain? What purpose is it serving? And we think that the endocannabinoid system serves an important role in sleep, appetite, very importantly and relevant to schizophrenia. It may play a role in neurodevelopment, in telling neurons where to go, when to connect, and so on and so forth. As you might know, we are born with billions of neurons, and during adolescence, the brain undergoes a massive change where many neurons are removed or pruned away. Connections that are important are retained, and connections that are not important are removed. And the endocannabinoid system may play an important role in this, and it may be disrupted by smoking cannabis.
Yeah.
What's changed in the landscape? Many things have changed in the landscape. The first is that the THC content of cannabis, this is what gives cannabis its potency, has changed dramatically over the last 40 years. In the 1970s, the THC content of cannabis was about 2%. Now the average THC content of cannabis is close to 18%. And likewise, the CBD content of cannabis has gone down. Besides cannabis, now we have a staggering array of products, cannabis derivatives, that have a THC content of almost 90%. These come with amusing names like earwax, green crack wax, and so on and so forth. These are products that have a very, very high THC content. And so, as you might imagine, use of these products might be associated with greater negative consequences. Besides these cannabinoids, we also have cannabinoids that are sold as medicines, including dronabinol, which is approved for chemotherapy-induced nausea and vomiting, and a few others. So I want to draw some important distinctions between the different effects of cannabis when they're consumed in different ways. So when one smokes cannabis, that enters the brain almost immediately. THC enters the brain almost immediately. One has the capacity to titrate the effects almost in real time. So let's say you want to get a certain degree of high. If you're not feeling that high, you take another hit. Conversely, if you're feeling too intoxicated, you just don't take another hit and you'll feel okay fairly quickly. In contrast, when someone consumes an edible, the effects only emerge about 90 minutes later, shown here in the green line. About 90 minutes later, the effects emerge. They peak around 3 hours and they go away several hours later. In contrast, when one smokes, you're back to normal usually within less than an hour or so. This is an important distinction between the effects of cannabis when it's consumed by smoking it or inhaling it versus using it as an edible. Okay, the other difference in landscape is, according to the federal government, and this may change, cannabis is a Schedule I substance and it's banned for use. Whereas many states, including the state of Connecticut, has now approved cannabis both for recreational use and for medicinal use.
Because you talked about how the rate of THC, has increased through the years. Can you talk about how the generations of plants contribute to that? Through the years, when people are growing marijuana, and then because I've always heard that the more generations of plants, the seeds and so forth, create a higher concentration of THC in the plant.
That's a good question. I don't think it has anything to do with generation. It has to do with genetic modification. So these are plants that are genetically modified and selected for their high production of THC, and it can be engineered. These are basically genetically engineered plants. You can make cannabis plants. You can instruct by altering the genes of a cannabis plant for it to make more THC. In contrast, you could genetically modify it to make more CBD. So that's the reason why these plants currently, or the cannabis that's being sold right now, it's very deliberate. It's been engineered to produce high amounts of THC. I see a question here in the chat, a very important one. If someone is using CBD, is it possible to test positive for THC? Most CBD products that are sold out there often contain small amounts of THC. And this is very important for you to know if you're planning to use CBD or if your patients are planning to use CBD. That is to say that if you're tested, you might test positive for THC. And I know of, for example, in the federal government, if you test positive for THC, you could lose your job. And I know of a number of cases of people who innocently went to Bed Bath & Beyond, purchased CBD, used it for back pain, and were drug tested and tested positive and had to face consequences. So just keep that in mind. Are the THC vapes immediate as well? Yes, indeed. Because vaping and smoking is basically through the pulmonary route through your lungs, there's not much difference between vaping and smoking in terms of the immediacy of effects. What's different is that whereas when you smoke, there are a lot of other combustibles that have negative consequences. When you vape, you don't get all that other junk. So vaping in some regards is safer for your lungs, but not safer for your mental health. All right, so next, cannabis as a risk factor for new psychosis. Before that, I want to define a few things. I want to make sure I make some important distinctions. The distinction between psychotic symptoms, which you all know as hallucinations, delusions, paranoia, disorganized speech, and the like, and a psychotic disorder, which is much more than just psychotic symptoms. Psychotic disorder, like schizophrenia, includes, importantly, negative symptoms, cognitive deficits, mood symptoms sometimes, that all lead to functional deficits. So as I'm describing you the relationship between cannabis and psychosis, I'd like you to keep this distinction in mind, the distinction between psychotic symptoms and a psychotic disorder. So the idea that cannabis is related to psychosis is not a new one. It was described almost 200 years ago by the French physician Moreau, where he described hashish users in Paris, where I am currently, as having psychotic reactions lasting a few hours. This is translated from French. Occasionally, as long as a week, the reactions seemed dose-related, included paranoid ideas, illusions, hallucinations, delusions, depersonalization, confusion, etc. Now, these were described before the concept of schizophrenia was even conceived, but you would all agree with me that these are symptoms that we typically associate with psychosis, hallucinations, delusions, etc. Moving on, in India, which is where I'm originally from, when they colonized India, had an Indian drugs commission because they were concerned about the risk of psychosis in Indians who were using cannabis. And I just highlighted the key area here, which is that they say the moderate use of these drugs didn't produce mental injury, but excessive use would produce mental injury and intensify mental instability. Likewise, it was first described back in the 1930s, the concept of Indian hemp insanity, where people were becoming psychotic after using cannabis. Now, I wouldn't agree with everything that's written here, but this is just to make the point that the relationship between cannabis and psychosis is not a new one. That's been recognized a very, very long time ago, even before the concept of schizophrenia was well recognized. So I would argue that one way of thinking about the relationship between cannabis and psychosis is the temporal relationship between the two. And I'll try and explain that, and please stop me if you don't understand me. I would argue that there are three distinct relationships between cannabis and psychosis. The first on your far left is that of psychosis that occurs immediately following exposure, but that does not extend beyond the typical period of intoxication. And the typical period of intoxication with cannabis, at least when it's smoked, is about an hour or so. With edibles, it can be up to 3 hours. So that's one relationship. The second is that of psychosis that occurs after exposure. But in this case, the psychosis lasts well beyond the period of intoxication, sometimes days and up to weeks. And this often requires some kind of clinical intervention. And the third relationship is that of exposure to cannabis in adolescence, followed months to years later by a persistent recurrent psychotic disorder that we currently call schizophrenia. So let me try and illustrate this to you. The idea of an acute psychotic state would be where exposure to cannabis or cannabinoids produces intoxication. And during that period of intoxication is when one experiences psychosis. What's the data to support this? So let me go back. So the second relationship is that of psychosis that persists well beyond intoxication. The intoxication period is shown here in yellow. And the third is where the psychosis begins well after the intoxication and continues and recurs through the years. There is now experimental evidence and anecdotal evidence and lots of evidence from converging lines suggesting that there are some acute effects of THC and cannabis that overlap with the symptoms of schizophrenia. So in laboratory studies, THC has been shown to produce hallucinations, delusions, paranoia, negative symptoms, cognitive deficits, which are also known to occur in schizophrenia, and a number of alterations in the EEG or the brainwave activity, which is also known to occur in schizophrenia. The second relationship is that of psychosis that begins after exposure but persists beyond the period of intoxication and can last sometimes from days to weeks and often requires clinical intervention. So this condition often recurs with cannabis use. It often resolves when a person stops using cannabis, and it often, as I said, requires clinical intervention. What is interesting is that in individuals who experience cannabis-induced psychosis, which is what I just described, if you look at what happens to them in the years following, it seems like many of them are re-diagnosed with a schizophrenia spectrum disorder. So this was a study done in Finland involving almost 20,000 people. They looked at individuals who had been taken to the ER hospital or hospitalized for cannabis-induced psychosis. And they looked at what happened to them in the ensuing 8 years. And depending on what criterion you used, in the case of cannabis-induced psychosis, 47% of them were re-diagnosed with the schizophrenia spectrum disorder, suggesting that having a cannabis-induced psychosis is a harbinger or heralds the onset of schizophrenia. I want to talk a little about the third syndrome, which is that of cannabis and later recurrent psychosis. There have been a number of epidemiological studies that have shown that if you use cannabis, your risk for developing schizophrenia is about fourfold. This graph that I'm showing you is referred to as a forest plot. And these are all the different studies that have been done looking at the relationship between cannabis exposure and psychosis. When you put all these studies together, and there are many of them that have been done over the last 25 to 30 years, it looks like your risk for schizophrenia is about fourfold higher if you use cannabis in adolescence, particularly in adolescence. There's a more recent study, a very large study that I'll spend some time talking about. This was a study published in Lancet Psychiatry a few years ago that involved a number of European countries and Brazil, where they looked at the relationship between the frequency of cannabis use, as in everyday use, versus weekly use, versus monthly use, versus never use, and the amount or the potency of cannabis that was being used, and that relationship to psychosis. What they found was that the highest risk for psychosis was in those individuals who used cannabis every day and who used a particularly high potency form of cannabis called skunk cannabis. Skunk cannabis typically contains about 10 to 15% THC. But as I mentioned earlier, we now have products that contain up to 80% THC. So you can imagine if you had to extrapolate that onto this chart, the risk would be even higher than what it is. And in this case, the odds ratio shown here in the last few columns suggests that your risk is about 5.81 times more than those who had never used. What we do know about this relationship between cannabis and psychosis is that The earlier a person uses cannabis, the greater the risk. The heavier they use, as in the more frequent they use, or the more potent forms of cannabis they use, the greater the risk. And then the longer they use, as in the cumulative years of exposure, the greater the risk. So this is something to keep in mind. So another way of putting that would be if a person starts using cannabis after their brain has developed, which we think happens around the age of 25 or 26, they may be at less risk for developing a psychotic disorder. We also know that the window during which psychosis typically occurs is between the age of 15 and 25, when the brain is developing. And I'll speak about why this may be important for us to keep in mind as we think about harm reduction. Something important for you to keep in mind is that obviously not everyone who uses cannabis develops psychosis, and not everyone with a psychotic disorder was exposed to cannabis. The analogy I would use here is that not everyone who smokes cigarettes develops lung cancer, and not everyone with lung cancer has smoked cigarettes. We acknowledge that smoking cigarettes is a modifiable risk factor for lung cancer. So this is another way of saying that cannabis is neither necessary nor sufficient to cause schizophrenia. We think of it as a component cause, one that interacts with other risk factors that we don't fully understand, possibly genetic factors, to confer a higher risk of psychotic disorder. But because we can't do much about our genes, right, at this point in time at least, we can do something about a modifiable factor like cannabis. And that's why it's important for us to keep in mind, even though it may be only a component cause. Just to put that in perspective, going back to my analogy of lung cancer and smoking, if you're a non-smoker, your risk for lung cancer is about 1%. If you're a cigarette smoker, your risk for lung cancer is between 10 and 20%. So it's about 10 times higher, your risk. And men who smoke 1 packet a day have a 10-fold greater risk. Those who smoke 2 packets a day have a 25-fold greater risk. Obviously, the data at the present time linking cannabis to psychosis is not as robust. As I mentioned earlier, if you put all the epidemiological studies together, it would suggest that your risk is about 4 times greater. But I did show you some concerning data suggesting that the heavier the exposure and the more potent forms of cannabis can increase your risk even greater. And as cannabis is becoming more available and more potent forms of cannabis are becoming available, it's conceivable that the risk of psychosis with cannabis is going to increase. Currently, though, the risk of psychosis with cannabis is probably in the same ballpark as the risk of heart disease from hyperlipidemia.
Is it the reason why maybe the psychotic breaks get worse if pot continues, or the psychosis gets worse because pot continues? Is it because the THC creates excessive pruning? And so it's like actually damaging the brain or taking away. I know that pruning's normal in adolescence, but then the THC, I understand, can create an excessive pruning. So can that actually cumulatively then create excessive pruning to the point of damaging the brain and creating a long-term psychotic disorder?
I think that we don't fully understand how cannabis or THC is producing this. We have some leads, and you're on the right track in suggesting that. So as I mentioned earlier, we think that the endocannabinoid system may play an important role in pruning and neural migration and things like that. And that's what happens during adolescence. We think that when someone consumes cannabis during that age, the cannabis interferes with the normal endocannabinoid system and therefore interferes with pruning. There are some studies in animals, obviously you can't do this in humans, that show that if you expose young animals at different stages of adolescence to cannabis or THC, and you stop exposing them after a while, they will show alterations in their brain as adults, suggesting that exposure during critical phases of brain development may lead to long-lasting consequences. So that's our best guess, and that's the reason we need to do research. We need to better understand exactly how this is occurring.
There is a question about wondering if it can be concluded that there might be some people who might not have developed schizophrenia if they had abstained from cannabis.
That's a great question. That's that chicken and egg question we may never be able to answer. I mean, I think one way of thinking about it might be the analogy of lung cancer and smoking. We know that lung cancer, smoking is neither necessary nor sufficient, but we know that it's a modifiable cause. And I suppose every person who has lung cancer who smoked will be wondering, would I have had this had I not smoked cigarettes or not? We can never really tell. But we think cannabis, and we are accumulating more and more evidence that it may contribute to the risk of schizophrenia. So, and likewise, even if you have a family history of schizophrenia, even if you have the genes for schizophrenia, not everyone will have schizophrenia because of that. So even genetic factors are not do not account for all of the risk of schizophrenia. We think that, like most chronic and complex diseases, there's some complex interaction between environmental and genetic factors.
I was just wondering, is there any evidence of people getting better from the diagnosis of schizophrenia after like not taking the cannabis?
Yes, absolutely. If you just think about schizophrenia is a very heterogeneous illness, meaning to say that some people do get better for reasons we don't understand, and some people continue to have symptoms for reasons we don't fully understand. So, it is definitely possible. We also know that cannabis-induced psychosis, which was the second syndrome that I described, the way that it's been traditionally described is that if people don't use cannabis, the psychosis doesn't recur. And conversely, if they resume using cannabis, the psychosis does recur. So I'm a psychiatrist, and I've been working with people with serious mental illness since around 1992, and I was quite perplexed as a young psychiatrist that my patients in their sessions would tell me, oh, when I smoke weed, it makes me feel better and my symptoms get better. And I would see those same people in the ER or admitted to the hospital. And I could never quite, reconcile this contradiction that on the one hand, my patients were saying weed made them feel better. On the other hand, clinicians were seeing people who were using weed end up in the hospital. At the time, the main hypothesis that was proposed was something called the self-medication hypothesis, according to which people with individuals with schizophrenia were using cannabis to self-medicate certain symptoms of schizophrenia, such as hallucinations, delusions, etc. But when I looked more closely at the literature, there wasn't any evidence to support it. It made a lot of common sense, but there wasn't much evidence to support it. The only evidence that was out there were surveys of individuals with schizophrenia who were using cannabis. And the usual way these surveys are done is you ask people, why are you using cannabis? And it's often you're asking them well after the fact. That is, you're not asking them when they're intoxicated or when they're using cannabis. One thing we know for sure is that cannabis messes up your memory. And so it may impair your recall of what actually happened. And we know that in substance use disorders, denial and rationalization play very important roles. And if you ask anyone, whether it's someone who's using opioids or someone who's using alcohol or misusing alcohol, they will give you a very good reason why they think they're using alcohol or opioids. That might not necessarily be the reason that they're using alcohol. So we actually did a study where we invited patients to take part in a study where they received in a double-blind placebo-controlled study. And we concluded from that study that THC worsened the symptoms of schizophrenia. It made positive symptoms worse. It made negative symptoms worse. And it impaired memory to a much greater extent than THC did in healthy individuals without any schizophrenia. So this is summarized here. the limited experimental studies that have been done, there is no evidence, not a shred of evidence to support the self-medication hypothesis. A colleague of mine in the Netherlands did a different kind of study, not an experimental study, did a study where she asked patients while they were in their homes smoking cannabis, how they were feeling after they smoked cannabis, how they were feeling before and after they smoked cannabis. Basically, this is what she found. It's highlighted here in yellow. The mood-enhancing properties of cannabis were acute, whereas psychosis-induced effects were subacute. There was no direct evidence for self-medication. I'm going to try and illustrate what my hypothesis for what may be happening. So think of time on the x-axis here and the change in symptoms on the y-axis. So I think what may be happening when individuals with schizophrenia smoke cannabis is that they have an initial feeling of high. They also have a reduction in anxiety, but then the increase in psychosis happens later, which they don't anticipate. I think what may be happening is individuals with schizophrenia are using cannabis for the same reason that most other people use cannabis, which is to get high and to chill out, as in to have less anxiety or less stress. But what they don't anticipate is soon after these effects wear off, they do have an increase in psychotic symptoms. This is my best explanation for what might be happening. And certainly this is not supportive of a self-medication hypothesis. I no longer use the self-medication hypothesis terminology in my practice working with serious mental illness patients, because I've studied this with alcohol, I've studied it with nicotine, and we find no data to support that either alcohol, cannabis, or nicotine improve any of the core symptoms of schizophrenia. I just spoke about the acute effects of cannabis. What about the effects of repeated cannabis use on the course and expression of someone who has established schizophrenia? I'll draw your attention to a study that was published a few years in Lancet Psychiatry, where they followed about 260 people with first episode psychosis. And some of them were using cannabis. Some of them used to use cannabis and were no longer using cannabis. Some of them never used cannabis. Some of them used cannabis every day and used very high potency cannabis. And they looked at outcomes including hospitalizations, relapses, and so on and so forth. The gist of this is that continued users of cannabis, this was a longitudinal study, continued users of high frequency and skunk-like cannabis had the worst outcomes. They had the most number of relapses. They were at greater risk for relapse. They had fewer months between relapses, and they needed more intensive psychiatric care. So this particular study just illustrates many other lines of evidence suggesting that there are negative consequences of cannabis use on the course and expression of schizophrenia. And that includes hospitalizations, it includes non-adherence to medication, it includes ER visits, includes problems with the law, and so on and homelessness. These are the usual negative consequences associated with cannabis use in schizophrenia. Now, what about those who are at risk for schizophrenia? So what do we know about risk for schizophrenia? Right now, unfortunately, the only obvious risk factors that we know for schizophrenia is a family history of schizophrenia. If you have a family history of schizophrenia, you are at greater risk for developing schizophrenia. And then we also know there's another way of describing clinically high risk, as in individuals who are reporting maybe attenuated psychotic symptoms or psychotic-like symptoms. We call them clinically high risk individuals. So these would be the two categories. What do we know about their risk when they use cannabis? What we do know is that in experimental studies done at Columbia University, they showed that when they compared individuals who were clinically high risk and compared them to age and gender match controls, and they took part in a study where they smoked a joint of cannabis in the lab, those who were clinically high risk seemed to be more vulnerable to the paranoia-inducing and anxiety-inducing effects of cannabis. Both groups had similar levels of intoxication and high, but only the CHR group showed an increase in anxiety and an increase in paranoia. So these data, though it's a very small study, would suggest that if you're clinically high risk, you may be at greater risk for some of these effects of cannabis. My colleague has done a study in those with a family history of schizophrenia. And in a laboratory study, we find that those with a family history of schizophrenia may also be more vulnerable to some of the effects of THC in the lab. So the take-home message here is, in the patients that I worked with who have siblings who are still well, I usually advise them, please try and convince your brother or sister to refrain from using cannabis until after the age of 25. Or if they're going to use cannabis, to be careful, to be as careful as they can to avoid using high potency cannabis, etc. So that would be one of the implications of these findings. So what might one do in someone who has a psychotic disorder and is using cannabis? As I mentioned, it would be important to let them know that there's a greater risk of psychosis in their siblings if they use cannabis. What's important to recognize is the age of use, the potency of cannabis, i.e. the THC content and the CBD content are important. The frequency of use and the mode of use is also important. We also know that cannabis may interact with other substances in a negative way. And cannabis may also interact with prescribed medications like antipsychotic medications. If you were to adopt a harm reduction approach, one might consider advising people who are using cannabis who have schizophrenia to try and avoid high potency cannabis. And these days, if people are getting cannabis from a dispensary, most of the dispensaries, I think all the dispensaries in Connecticut are obligated to have on the label the THC content of cannabis. I would say anything greater than 15% would be considered high THC content from my perspective. So the lower the THC content, the lower the risk. If people are completely unwilling to stop using, you might consider advising them to reduce the frequency of their use, from instead of using 3 times a day to use maybe once a day, to decrease the amount that they're actually using. Those might be approaches to consider in a harm reduction model. Unfortunately, we do not have any treatments as yet for cannabis use in general, or cannabis use in people with individuals with schizophrenia. There are some promising leads, but nothing that is accessible to the clinic at the present time. Cannabinoids or cannabis can induce a transient psychosis. This can be described as a causal relationship. The effects are dose dependent. People with schizophrenia are more vulnerable. People with a family history and CHR are also more vulnerable. Why some people are more vulnerable and not others is $1 million question. I suspect it has to do with genetics. There's mounting evidence that cannabinoids can contribute to the risk of schizophrenia. An episode of cannabis might herald the development of chronic psychotic disorder. As I mentioned earlier, the age of exposure and the dose of exposure are important. And cannabis may precipitate or hasten psychosis in individuals with a high risk for psychosis, as in family history. And again, the $1 million question is why others with no obvious risk of psychosis are more vulnerable is not clear. So I'm going to stop there and open it up for questions in the remaining time that we have.
There's a variety of things in the chat.
So I see Amy has a comment here about a cap on the THC content. I agree, Amy, that we have to partner together. Families and clinicians have to partner together to convince our legislators to have some reasonable caps, because there's a whole generation of kids out there who are going to be exposed to these very high THC content products. And the only way we're going to be able to stop that is if we have regulations that limit the THC content. There are areas that have done a good job at that. For example, the province of Quebec in Canada has very strict limits on the THC content and labeling too. We just have to convince our legislators. Can being on an antipsychotic protect one from going into psychosis if a relapse to THC occurs? In some of the experimental studies that were done, despite the fact that the person was taking antipsychotic medications and despite the fact that they were stable, they still experienced an exacerbation of psychosis. So while antipsychotic drugs may be protective, they're not foolproof, or they won't guarantee that a person will not have a relapse. And that's really important. So that's a big risk. I would just say, if you can, try not to use. Someone has a comment where it had become legalized many years ago and they were seeing many problems. Yes, Colorado is seeing problems, and Connecticut is going to catch up in due course, but we need to be vigilant.
Looks like there's a question about if you can speak to any of the promising leads regarding treatment.
There are some studies using something called rapid transcranial magnetic stimulation, which is basically stimulating a part of the brain using magnets. And there's a preliminary study done by a former Yale professor who's now at the University of Toronto using RTMS. His name is Dr. Tony George, and he's shown some effect on reducing cannabis use in patients with people with schizophrenia using RTMS. Dr. George used to work at the Connecticut Mental Health Center several decades ago. We had done a very intriguing study a few years ago using a drug that increases the brain's own cannabis-like substance, but does not produce psychosis. And we showed that we were able to limit cannabis use in individuals who did not have schizophrenia, but that research is still quite early. Of course, there are psychological approaches like CBT and motivational interviewing that can be used. So that's the other.
Yeah, hello. You partially answered my question just now. My question is kind of anecdotal evidence-based curiosity. First time or mild users who have little or no known risk of psychosis experiencing psychotic symptoms when using THC substances.
Yeah, so as I said earlier, the challenge we have is that we don't have a good idea of what puts someone at a greater risk for schizophrenia. The most obvious one is a family history, but as I mentioned, even if you have someone with a family history of schizophrenia, that doesn't mean you're definitely going to get schizophrenia, right? We know that. What does seem to be the case is that the more you use, the greater you're at risk. And the more potent forms you use, the greater you're at risk. But we still don't have a good way of identifying who is at greatest risk for this. And that's what we need good research for.
So someone who has more of the psychotic disorder, I'm wondering your thoughts if you have any thoughts about neurofeedback. I don't know if you have any feedback or thoughts on neurofeedback. So
I'm not sure exactly what you mean by neural feedback. So it will be hard for me to respond to that.
Yeah. So it's my understanding that it's usually twice a week over at least 20 sessions where they kind of place these things on the different parts of your brain, and it kind of re-regulates itself. So it's showing your brain, I guess, kind of how to re-regulate itself. So people that have suffered from trauma or mental illness, they're finding that it can help restart the brain, I guess, or retrain the brain.
So that's very intriguing. I can't really speak about the neural feedback without knowing exactly what it is. I would be cautious in saying anything about it without knowing the details. But we do know that there are established treatments for psychotic disorders that have a wealth of data to support both their benefits and knowledge about their side effects.
So I think we need to wrap up for now, but Dr. D'Souza, thank you so much. I mean, clearly everyone was very interested and have lots of questions, and the chat is, expressing a lot of gratitude and that they learned a lot from your talk. So we really appreciate your expertise on such an important topic, and thanks for everyone's attendance and participation.
Thank you.